Good morning. Thank you very much once again to all my colleagues attending the Hepato Pernambuco 2021 Liver Talks webinar. It's my great pleasure to begin this scientific event today with a liver talk, the future of autoimmune liver disease. It's also an honor to have my colleagues, Dr. Cristine Villela from Rio de Janeiro. She is a full professor of hepatology from Faculdade de Medicina Federal da Universidade do Rio de Janeiro, who will moderate this roundtable with me and will introduce the international speaker, debaters, and presenters of the clinical case. My special thanks to Professor Michael Heneghan, who shared with us the roundtable organization. We also prepare a small tribute to celebrate the Hepato Pernambuco Liver Talks Jubilee. Welcome to Liver Talks today.
15 anos do IFP, Instituto do Fígado e Transplante de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
To begin the roundtable, I'd like to introduce my friend, Professor Michael Heneghan, consulting hepatologist, Professor of Hepatology, Institute of Liver Studies, King's College Hospital, to deliver the mini conference, Improve the Management of Autoimmune Hepatitis. Thanks, Mike. Welcome.
So thank you all for inviting me. It's a real pleasure to be back in Recife virtually, even if it is not in person. I would love to be with you in person. We're still getting over the Euros just in the same way as you're all getting over the loss of the Copa Americana. And as somebody who supports Liverpool and Roberto Firmino and all the Brazilian players in Liverpool, I'm feeling particularly sad. Anyway, I'm sorry that we can't be there in person. We've had some great times in Recife and Porto de Galinas and in Fernando de la Noronha, and we look forward to getting back there again. So I'm delighted that I have Jonathan Potts with us today. He'll be joining us from the Royal Free Hospital. John was one of my fellows, and he is becoming a rising star in the field of primary sclerosing cholangitis. And we were hoping to have James Neuberger, but unfortunately he won't be with us. But we will still discuss primary biliary cholangitis. So I'm going to focus on autoimmune hepatitis. It is a chameleon disease, unquestionably. And when we say chameleon, we mean this is a disease that presents in multiple different ways, from asymptomatic disease to patients who have a very acute hepatitis with jaundice, cholestatic hepatitis. They may present with acute liver failure or indeed cirrhosis. And the paradigm of management is one of drug therapy, whereby you hope you get success and control, or alternatively, a proportion of the patients have burnt out disease. And if you burn out, the question then is whether or not you will succumb to the disease or require liver transplantation. It is important to consider definitions because, as I say, this is a chameleon disease, presents in both acute and chronic forms, including an acute icteric hepatitis with or without acute liver failure, and indeed can present as acute on chronic liver failure. So when we're talking about these definitions of acute hepatitis, acute severe autoimmune hepatitis, or acute severe autoimmune hepatitis with liver failure, our standard presentation with jaundice, no coagulopathy, no encephalopathy, progressing through with coagulopathy, and finally coagulopathy with encephalopathy. And it is important to differentiate these three groups. And what we also know, and this is data from Sheila Sherlock, an old study, that actually treating patients with autoimmune hepatitis impacts upon survival. Early study following patients for 5 years and then following them on steroids versus no treatment. Steroids save lives in this disease. And the paradigms of management from the EASL clinical practice guidelines: prednisolone 0.5 milligrams to 1 milligram per kilogram as an initial therapy, followed by the addition of azathioprine after 2 weeks, is first-line treatment of autoimmune hepatitis. And indeed, it is felt that the initial azathioprine dose should be 50 milligrams a day and escalated to a maintenance dose of between 1 and 2 milligrams per kilogram per day. So what are the parameters that outline prognosis and survival? Well, obviously the presence of cirrhosis at the onset is of critical importance. What we know, these are data from Jordan Feld, now 20 years old, from Toronto, that if you have cirrhosis after 10 years, you have only a 60% chance of survival, whereas if you're non-cirrhotic, the chance of survival is well above 90%. We also know that actually having liver decompensation, as well as having cirrhosis and failure to normalize the ALT within 12 months, also impacts upon long-term survival. Also, the more relapses you have per decade impacts upon your survival outcome. And these are data from Dermot Gleeson and his group in Sheffield. In the US, and indeed also in the European guidelines, the other option is to consider budesonide 6 to 9 milligrams per day in non-cirrhotic patients with the addition of azathioprine. And these are data, again, looking at complete response at 6 and 12 months. And I would draw your attention to number or letter D, this panel, whereby at 6 months what was found was that actually a slightly greater proportion of patients were achieved biochemical remission, AST and ALT, within the normal range after 6 months, and after a composite endpoint of based on intention to treat, including steroid-related side effects, a greater proportion of responders in non-cirrhotic patients. Don't forget that if you must exclude patients with cirrhosis, mainly because these patients will shunt, and this is essentially a topical corticosteroid. These are data, pooled data from a number of centers across Europe, and this is looking at whether or not high or low dose of prednisolone is associated with better outcomes. So conventional dosing of 40 milligrams per day of prednisolone versus the types of regimens seen in Germany and France, up to 80 milligrams a day. Is there a difference in the rates of biochemical remission with normalization of IgG levels at 6 months? The answer is there is no difference. But what is also noteworthy is that actually we're still only achieving response rates of remission rates of approximately 60%. So we're not doing so well with this disease. And if you look at granularity in terms of, even if you look at lower doses, 0.31 milligrams per kilogram, roughly 20 milligrams of prednisolone a day versus 40 milligrams versus 80 milligrams, you can see that there is a sweet spot, likely somewhere around 30 to 40 milligrams per kilogram, that achieves the best response rates. And of course, the problem is the rates of steroid-related side effects. And although there was no statistical difference between the rates of these complications based on low doses of prednisolone versus high doses of prednisolone, we know in clinical practice that the rates of diabetes are higher on higher doses. The rates of osteopenia are not inconsequential. So even though the rates of osteoporosis did not reach statistical significance, it is not inconsequential. The other concept that we have been trying to develop with the Dutch cohort, and again, this is a multi-center cohort that included King's, the concept of how quickly patients respond at week 8 allows you to stratify patients over time. And in fact, if you have a greater than 80% drop in AST or indeed ALT by week 8, you can see that there is a significant difference in patients who respond to their drug therapy compared to those that don't. And this is seen over both 5, 10, and 15 years. So what can we conclude? We can conclude that patients who have inflammatory autoimmune hepatitis, higher levels of AST and ALT, and this is times the upper limit of normal. So AST levels 20 times the upper limit of normal, more inflammatory disease, these patients do better. Bilirubin levels also tend to be higher, so more icteric, more inflammatory. What we also know, this is a Dutch study recently published, that again, this concept of response at 12 months, if you normalize your AST, ALT by 12 months, get it below the upper limit of normal, these patients do better than those that are living between 1 and 2.5 times the upper limit of normal. So the goal of treatment has to be trying to achieve normalization of the transaminase activity. But that's all fine and good. In the long term, what we do know is that we need to be trying to increase the dose of azathioprine to minimize steroid therapy, and also try and understand that if you can get azathioprine monotherapy at 2 milligrams per kilogram per day, over 80% of patients can achieve a long-term remission. Remission is defined increasingly by 3 or 4 items, although in our recent consensus document, we are excluding symptoms: inactive liver biopsy, hepatic activity index less than 4, normal immunoglobulin levels, normal AST, ALT. The original paradigm included symptoms, but actually symptoms precipitate steroid therapy. Is autoimmune hepatitis treatment potentially a lifelong treatment? These are data originally from King's in the early 80s, and these are data in the last decade from Holland. And what I would bring your attention to is that the majority of patients who you take off all treatment, whether it is steroid-related treatment in isolation or combination steroids and azathioprine, 80% relapse within 2 years of stopping treatment. So our paradigm of management is that treatment of autoimmune hepatitis should be response-guided, treatment regimens should be individualized, so think about patient care. If you have no response, think about other diagnoses. If things are not behaving as they should be, consider whether or not there might be overlap between PBC, PSC. Think about metabolite monitoring or patients taking their medication, and consider a liver biopsy. What we know with regard to azathioprine from inflammatory bowel disease is that patient variability is important, both in terms of pharmacogenetics, pharmacokinetics, and pharmacodynamics. And actually, with azathioprine, we have tools to potentially manage this. These are data from King's just published in the Journal of Hepatology that suggests that if you use drug levels to help monitor and improve efficacy, you can improve the overall response, the response rates by reducing the likelihood of having patients who are not in remission. Now, these are patients, you may say, they are more difficult to treat because they have ended up on slightly more steroids, but actually you can see that there is a significant difference if you just standard weight-based dose versus measuring metabolites. What we also know about metabolites is that they can be helpful, I think, increasingly in looking at efficacy, toxicity, and compliance for patients taking the medication that we believe. What about patients that don't respond? We are thinking about the combination of long-term side effects versus salvaging response. And we have a list of medication that we are using, including budesonide, mycophenolate, tacrolimus, cyclosporin. Actually, in real life, the majority of experience sits with the use of Cellcept or mycophenolate. Transplant centers use more tacrolimus or cyclosporin, and actually the amount of patients treated with other agents is very small. If you look at the response rates for mycophenolate, 154 patients in a group of non-responders, a group of partial responders, and complete responders, the people who have no response are unlikely to improve with mycophenolate. So if you have people who are intolerant of azathioprine, mycophenolate is a good drug. It gets about a 50% response in people who are partial responders, but if you're not responding to treatment, it doesn't work particularly well. In contrast, if you have an efficacy problem where you have treatment that isn't working particularly well, actually tacrolimus-based immunosuppression increases the proportion of patients who are going to respond, who are in the partial response group or in the non-response group. And also, there is no difference, however, between the long-term survival. In Germany, and indeed occasionally in the United Kingdom, we're using anti-TNF therapy for, like infliximab, for a difficult to treat disease, an infusion of 5 milligrams per kilogram every 4 weeks. This seems to be helpful. Don't forget liver transplantation in the patients that need it, particularly those patients with cirrhosis, HCC, or who develop acute liver failure. But also don't forget that this disease recurs in about a quarter of our recipients. Have a particular attention on patients with more severe disease. INR is greater than 1.8. Even if you give them, you may be able to salvage approximately 50% of patients, but if you don't treat them, you're going to end up transplanting them. And of course, the people that we're unlikely to treat are those with much more severe disease. And of course, these patients all go on to be transplanted. So here we are. To summarize, basically my advice is that autoimmune hepatitis, rare disease, but should have an individualized approach to treatment. It should be response guided. There's increasing experience of multiple agents. Try and identify the true non-responders because this is important for patient outcomes. And finally, please try and identify transplant candidates early. Thank you so much for joining us today, and I hope that you found this valuable.
Thank you very much, Mike. As usually, very clear and excellent presentation. Now I pass to Cristine Villela to introduce Elsie and the debaters to our roundtable today.
Thank you, Leila. First of all, it's an honor to me to be here, celebrating with you and all my colleagues this outstanding event. And I'm glad to introduce and to invite to present the first clinical case, Professor Elsie Oliveira, who is a professor from the Centro Universitário Lusíada e médica pesquisadora da Universidade Federal de São Paulo. After the presentation of the clinical case, we'll have the pleasure to present our colleagues who will discuss the clinical case, who will be Professor Eduardo Cançado, who is a professor, associate professor da Faculdade de Medicina da Universidade de São Paulo e médico do Hospital de Clínicas da USP, Professor Paulo Bittencourt, coordenador da unidade e hepatologia do Hospital Português, e Professor Cláudia Couto, who is also an associate professor do Departamento de Clínica Médica da Faculdade de Medicina da Universidade Federal de Minas Gerais. So first, Elsie, it's a pleasure to have you here to present the first case. Thank you.
Hello, everybody. Eu gostaria inicialmente de agradecer o convite, especialmente à professora Leila, e dizer que é uma honra para mim estar aqui, especialmente nessa comemoração que é o jubileu de prata desse evento tão importante que é o Hepato Pernambuco. Eu vou falar de um caso clínico de uma paciente de 45 anos, feminina, branca, casada, fisioterapeuta, natural e residente em Santos, São Paulo, que passou em primeira consulta em setembro de 2020 com uma história de 4 dias de fadiga, colúria e icterícia. E essa paciente tinha um histórico de 2013 ter apresentado um quadro de icterícia, e na ocasião ela foi investigada, acompanhada, inclusive realizou biópsia hepática, e nessa biópsia mostrou apenas catose em 100% com uma balonização. De história familiar, ela tem um hipotireoidismo, não é tabagista, não é etilista, nem ocasional, e não tem histórico de uso de drogas. No exame físico, o que chamava atenção, o índice de massa corpórea de 29, a presença de icterícia, 3 cruzes em 4, um abdômen flácido, sem hepatosplenomegalia, apresentando um traube maciço. Não apresentava estigmas de doença hepática crônica e nem edema em membros inferiores. Nos exames complementares, chamava atenção o nível de elevação das aminotransferases, né, em torno de 13 a 15 vezes o limite superior da normalidade, com predomínio da AST, uma gama GT elevada 6 vezes, uma fosfatase alcalina em 1,4, uma bilirrubina total em 7,3, com bilirrubina direta de 5,2, uma atividade de protrombina de 66%, uma albumina de 3,3, com pico de gama-globulina de 3,7, que nós podemos observar aqui nessa eletroforese de proteínas, uma IgG de 4.835, bem elevada, uma IgM de 530, e um hemograma normal, a paciente apresentava plaquetas normais. Foi realizada, então, uma ultrassonografia, que não mostrou dilatação de vias biliares, e mostrou a presença de um cálculo de 1 centímetro e uma esplenomegalia. Foi realizada ainda uma colangio-ressonância, e essa colangio-ressonância não mostrou anormalidade no trato biliar e confirmou os achados ultrassonográficos de colelitíase e de esplenomegalia. A astrologia das hepatites virais foram todas negativas, e na ocasião a paciente apresentava níveis de colesterol, triglicérides e glicose normais, assim como amilase e lipase normais. Essa paciente, então, evoluiu com uma piora, né, da função hepática, como nós podemos observar aqui no aumento do nível das aminotransferases, chegando a quase 19 vezes o nível de ALT e 15 de AST. Uma piora um pouquinho mais da fosfatase alcalina para 1,5, uma bilirrubina de 9,5, ela perdeu função, a atividade de protrombina diminuiu para 61% e a albumina caiu para 3. Com relação aos autoanticorpos, essa paciente apresentava positividade ao anticorpo antimúsculo liso nos padrões VGT contra vaso, glomérulos e túbulos, e apresentava ainda positividade ao anticorpo antimitocôndria nos padrões pontilhado fino, 1/320, e nuclear centromérico, 1/640. Com relação aos outros autoanticorpos, como o anti-ALKN1, o anti-CLA-LP foram negativos, assim como o anticorpo antimitocôndria, tanto na imunofluorescência indireta como o anti-M2, anti-SPC e anti-GP210 também foram negativos. Foi, então, instituído o tratamento, né, com prednisolona, na dose de 60 miligramas por dia, e essa paciente evoluiu com uma melhora importante dos níveis de aminotransferases, né, com uma melhora da bilirrubina, para 3,3, uma melhora na atividade de protrombina, 73%, quer dizer, ela saiu de 61% para 73%, uma melhora na albumina e uma melhora ainda nos níveis de IgG, mantendo níveis de IgM elevada e ainda mantendo apenas os níveis de gama-GT elevada. Então, aqui, eu fiquei bem feliz com 7 dias de evolução com o tratamento. Essa paciente foi biopsiada, né, 30 dias após o uso da prednisolona, por problemas de planos de saúde, e essa biópsia mostrava uma fibrose em ponte, né, com esboço de nódulos, múltiplos focos de necrose em saca bocada, presença de hepatite de interfase, um infiltrado periportal, portal e lobular, rico em plasmócitos, múltiplos focos de necrose confluente, ainda com formação de rosetas, aqui com as rosetas hepatocitárias, e mostrava ainda, em alguns tratos portais, a presença de lesão florida de ducto. Então, como nós já falamos, foi instituído o tratamento com a prednisolona, inicialmente a dose de 60 miligramas, com diminuição semanal de 10 miligramas, e foi iniciada a azatioprina em novembro, com a dose de 1,5 miligramas por quilo dias, com a dose inicial de 50 miligramas. Então, aqui é como essa paciente se apresentava em outubro, né, em com um mês de evolução, com a dose de 40 miligramas de prednisolona, óbvio que ela aumentou de peso, né, foi para 85 quilos. A gente apresentava uma melhora importante dos níveis de aminotransferases, com 1,9 de ALT, a ST normalizou, a gama continuava 7 vezes, mas a fosfatase alcalina normal, já não estava ictérica, né, clinicamente, com 2 de bilirrubina, recuperação da atividade de protrombina, aqui o AP de 86%, albumina de 3,4%, mantendo ainda um pico de gama-globulina de 2,1 e uma IgG de 2.500, além da IgM permanecendo ali em torno de 500. Em dezembro, ela, com a dose de 100 miligramas de asa e 10 miligramas de prednisolona, ela estava com aminotransferases normais, né, fosfatase alcalina, bilirrubina, TAP, albumina normais, mantendo o nível de IgG ainda em torno de 2.000 e apenas uma gama-GT aqui 4 vezes o limite superior da normalidade. E nos exames de fevereiro, depois que a dose, na dose de 10 miligramas de prednisolona de uso e 125 de azatioprina, foi observada uma elevação do nível dos aminotransferases, em torno de 2,5 vezes o limite superior da normalidade, uma gama-GT que aumentou muito, foi para 490, com 13, quase 14 vezes o limite superior da normalidade, graças a Deus, sem perder a função, né, hepática, bilirrubina normais, o TAP normal, e aqui a fosfatase alcalina, desculpa, e a albumina de 3,6. Então, aqui nós interpretamos, porque foi muito pontual com a elevação da dose da azatioprina, se por acaso essa paciente poderia estar fazendo uma toxicidade medicamentosa. E se então deveríamos solicitar os metabólitos da azatioprina, que foi o que nós fizemos. Então, como resultado desses metabólitos da azatioprina, nós observamos que os níveis de 6-tilguanina estavam muito baixos, estava 106, né, que o valor esperado de nível terapêutico é de 235 a 400, e a dosagem de 6-metilmercaptopurina estava muito elevada, 13.800, quer dizer, o objetivo é ficar menor que 5.700, porque acima disso você pode ter hepatotoxicidade, confirmando dessa forma uma toxicidade medicamentosa, uma hepatotoxicidade, né, a azatioprina. E nós podemos observar com esses níveis de 13.800, e nós vimos que ela não estava atingindo os níveis terapêuticos, e que estava realmente segurando a doença dessa paciente naquele momento era o corticoide. Então, nós optamos em reduzir a dose da azatioprina para 50 miligramas dia, e adicionamos 100 miligramas de alopurinol, o que nós sabemos que ele inibe a xantinoxidase, ele aumenta o desvio, né, do metabolismo da asa para os metabólitos ativos, que são os resultados da 6-tilguanina, para que ela conseguisse atingir níveis terapêuticos, e durante a evolução, nós tivemos a grata surpresa dessa resposta maravilhosa, com níveis de normalização de aminotransferases, fosfatase alcalina normal, bilirrubina normal, atividade de protrombina, albumina, inclusive a IgG e a gama-globulina normalizaram, mantendo uma IgM de 306 e apenas uma gama-globulina aqui de 3 vezes o limite superior da normalidade. Então, eu finalizo a minha apresentação com essas questões para os nossos debatedores, que são a presença de níveis elevados de gama-GT, elevação de IgM anticorpo anticentrômero e lesão florida de ducto são critérios para considerar como hipótese diagnóstica a síndrome de sobreposição? Haveria indicação para o uso de ácido ursodesoxicólico no início da terapia? O anticorpo antimitocôndria, ele deverá ser repetido durante o segmento? Quais são as implicações diagnósticas e terapêuticas da presença de lesão de ducto na hepatite autoimune? E qual a importância dos metabólitos da azatioprina no manejo do tratamento da hepatite autoimune? Muito obrigada.
Thank you, Elsie. Now we are going to start the discussion of this case. So I will invite our friends, Dr. Paulo Bittencourt, Dr. Eduardo Cançado, and Dr. Cláudia Couto. Maybe they could start answering the questions you proposed. So, who would like to start? Maybe Eduardo, would you like to start the discussion, please?
Yes, of course. Are you hear me?
Yes.
Are you hear me? Yes?
Yes.
Yes, Eduardo. Yes.
I would like to, Leila, thank you very much for your invitation. It's a pleasure to stay again. I were here last year. I was here last year, and I would like to congratulate Michael Heneghan for his presentation. This is a very interesting case, Elsie, because I think the main features of this case are related to autoimmune hepatitis. The patient has high levels of IgG, anti-smooth antibody with the pattern we observe in autoimmune hepatitis. The liver biopsy, the main features are all of them from autoimmune hepatitis. But your question, if the patient meets the criteria of overlap syndrome, yes, she meets because she has gamma-glutamyl transpeptidase higher than 5 times. Is one criteria of Paris criteria, right? And the other criteria is the florid bioduct lesion. 2 of them are the patient meets. But the most 2 important features, alkaline phosphatase higher than 2 times, and the presence of antimitochondrial antibodies certainly are not fulfilled in this case because they are negative. So I think although the patient has some features of overlap syndrome with PBC, I think we should treat this patient as autoimmune hepatitis. The centromere antibodies are not markers of autoimmune hepatitis. We have 2 patterns of antinuclear antibodies in autoimmune hepatitis, the homogeneous pattern and then speckled. The anticentromere usually is related to the presence of the limited form of scleroderma, a disease, a concurrent liver disease, usually together with PBC. So the high levels of IgM, anticentromere, high levels of IgG, the florid bioduct lesion, I think you should see these features as, I think you should follow this alteration. But the main side, I think we need to treat the main side of the overlap syndrome. In this case, it's autoimmune hepatitis.
Thank you, Professor Eduardo. So, Dr. Michael, would you like to comment on this case as well, please? And congratulations for your conference. It was really outstanding.
Thank you. I agree with Eduardo. There are some features. We have to think about whether this is histological overlap? Do we think it is biochemical overlap? Or is it serological overlap? And then you put them all together and decide whether or not this patient merits the diagnosis. I would say that the finding of some bile duct lesions is actually seen in initial biopsies in autoimmune hepatitis and also in treated follow-up biopsies. So you will see a bile duct lesion, perhaps not as florid as what is being described here, but I think I agree. The dominant disease is autoimmune hepatitis. Would we have started ursodeoxycholic acid from the very beginning? I don't believe so. I think urso in this condition is something to be added. And actually, I think what will be more valuable as time goes on is a repeat biopsy to see how things actually evolve. This would be my feeling.
Thank you. Paulo and Claudia, would you like to comment?
And I can comment. I'd like to thank Dr. Leila for the invitation. It's a great pleasure to be here, celebrating 25 years of the Pernambuco, and also congratulate Dr. Heneghan for excellent presentation, and also congratulate Elsie because I think she chose a very interesting case where we can discuss about many clinical, practical aspects. And I pretty much agree with Eduardo, and I will treat the patient as an autoimmune hepatitis. I don't think the GGT is related. It's not specific for cholestasis, so I would not introduce UDCA in this case because alk-phos is normal. But I agree that we have to follow up the patient closely, maybe ordering another AMA during follow-up, because if we have AMA positivity, we would have two features, and in this case, maybe use UDCA. But I have a question for Eduardo and Dr. Heneghan. Also, I don't know if they will answer the question, but it's related to azathioprine monitoring, metabolites monitoring. I think they're very useful, and especially because of this recent data presented, but we don't have it available on public health system. And we still have cases similar to this case that Els presented by Els. So my question is if we would use, actually if you would decrease azathioprine and add on allopurinol without the metabolites dosage in cases like this case, as we want to increase azathioprine. Our aim is to increase azathioprine.
Well, Claudia, how are you? Okay?
Yes, great.
I think it's impossible to use allopurinol without measuring the metabolites, because we performed, we measured this metabolite during 2 years at our hospital, and it's a very surprising result, with very surprising results. So there are patients who don't have any levels. The patient, they didn't intake the drug. Sometimes the levels of 6-thioguanine is very high, and it's really very difficult to decide if you put allopurinol and reduce 1/3, usually you reduce 1/3 of the dose of azathioprine. And you need again to repeat the dosage of the metabolite if this rearrangement was a good management, okay? I think it's very difficult I introduce allopurinol to see what will happen. But I think you need to check the metabolite again. I think it's,
Okay.
I don't use allopurinol without the dosage of the metabolites.
Thank you very much.
Michael, please.
Yeah, I agree completely. It's a very risky strategy. It can be completely unpredictable. And of course, this patient, I think the other thing that is important is the way that azathioprine behaves in individuals who have cirrhotic liver disease is different to how it behaves in people who have no cirrhosis. So I think if you are going to modify using allopurinol, metabolites is absolutely mandatory. And actually what the metabolites are very helpful about, always has been, is when are patients taking their drugs? Number two, are we overdosing with azathioprine? Because from patient to patient, it is so variable.
Thank you.
Okay. So thank you.
I think you in committee, Chris, there is some Q&A questions from Leticia Nabuco that she mentioned that this patient is overweight.
Yes.
Elevated gamma GT could be related to NAFLD.
I think the DGT is too high to be related to NAFLD. I don't know if you all agree with this. So although she has a high BMI and she probably could have NAFLD, I didn't see steatosis in the liver biopsy. I'm not sure. Else could confirm this. So I don't think the GGT high, as the patient presented, could be related to NAFLD.
May I pose a comment?
Only 10% steatosis on biopsy.
10%. Yeah, so
10%.
yeah.
Of course, Paulo, could you?
Okay, a great session. Congratulations to everybody. I think that maybe Elsie and Dr. Heneghan have talked before because the case highlighted very well some aspects that he have presented. The great fall in liver enzymes, and then the value of measuring azathioprine metabolites when you do not attain normal liver enzymes at 1 year. I agree with every comment that were said, but I would like to pose the same question to Professor Heneghan. It's very common to see an elevation of DGT with patients under treatment for autoimmune hepatitis, maybe because of corticosteroids, even if they are not in high dose. And with the normal alkaline phosphatase, I do not think that this patient have an overlap syndrome, but it's very common. Do you really worry about that in the course of the treatment of patients with autoimmune hepatitis?
So Paulo, you always ask great questions, and the answer is no, I don't worry about it. And actually, when you have patients with severe hepatitis, florid inflammation, we all recognize that the AST and the ALT go down first, and then you often go into this cholestatic kind of phase for a year where the gamma GT often goes up and stays up and can stay up for much longer. I generally don't worry about it, but actually the issue of something else going on? Could it be driven by steatosis? Could it be driven by high TGNs? Could it be driven by something else? Always worth considering, but generally I don't worry, particularly if the alkaline phosphatase is normal.
Okay.
I think, unfortunately, I have to move on. But for the last practical question, Mike, how can you manage your patients in the Kings? You still use azathioprine or use butazimide, or sometimes when you stop steroids, and if you do a liver biopsy before you stop steroid after 2 years?
So the liver biopsy discussion, patients don't like liver biopsies, so we're doing less and less of them. That much is clear. Budesonide I will use in younger patients, generally who are worried about the cosmetic side effects of steroids, who are non-cirrhotic, or older patients with milder disease. I tend not to use budesonide for very, very severe disease. And in terms of course, if you are going to withdraw all treatment, a liver biopsy is absolutely mandatory. I don't believe it's mandatory to be doing liver biopsies if they are on azathioprine or on a steroid sparing agent, particularly if you're just trying to get rid of corticosteroids. But I think individualized care, that is the key message.
Okay, thank you very much. I have to move on to the next
Leila.
Hi, Eduardo.
Can I make 2 questions to Michael to know about his opinion about 2 questions?
Sure.
Okay. Michael, how to explain why patients with the higher level of AST and ALT and bilirubin in your presentation, they had a better response?
So the answer is they have more viable liver at the time that they present. Usually if the AST and the ALT are much lower down, a lot of liver parenchyma has been burnt up. Similarly, you find that they will have had patients with lower levels when they present, lower levels of bilirubin, they are likely to have had inflammation present for a long time in an asymptomatic way. I think that is the explanation. I'm sure you've all experienced the same.
Okay. The other question is, you require an inactive liver in liver biopsy, not histological activity index less than 4 is different. You use different criteria from the ISO guidelines.
I thought the EASL guidelines were less than 4, or is it less than 3? I'm confused at this point. It's late in the day in London, but it's essentially an inactive liver biopsy.
Okay, let me carry on. It's my pleasure to introduce Dr. John Potts. He's a consultant transplant hepatologist and pancreatic biliary endoscopy at the Untitled Liver Unit, Royal Free Hospital. He will be delivering optional management of PSC. 15 minutes, Jonathan. Welcome to our meeting today.
Thanks very much. It's a real pleasure to be invited and to listen to the discussion thus far. Can I just check my slides are projecting? I'm going to try and do a bit of a whistle-stop tour through PSC for you. This is how I've broken things down. I'm going to try and go through a quick overview of PSC, the natural history, diagnosis, and then take you through our current treatments, including touching upon ERCP and liver transplantation, take you through a bit of some data regarding the patient experience in PSC, which I think is very important, and then go through the therapies that are currently under evaluation, and then give you some guidance based upon the recently published UK guidelines on general management and cancer surveillance. So I'm sure I don't need to remind many of you, but PSC is a chronic biliary disease. The etiology remains obscure, and it predominates in patients with IBD, and typically in men more than women, and has a predominance for the Northern European populations. And there's a variable prevalence across Europe. We know that about 3/4 of patients have coexistent IBD, and really PSC can be considered to be a distinct phenotype of IBD. And these are just a few of the things that, just to remind you, that most of the patients have ulcerative colitis rather than Crohn's, typically with the right side of predominance. There may be some backwash ileitis and rectal sparing, and often the IBD course is more quiescent than might be the case otherwise, but patients are more prone to pouchitis. And there's a very highly increased risk of both colorectal and HPV malignancies, which we'll come on to speak about. In terms of the diagnosis, the guidelines both from Europe, the US and the UK are fairly consistent that the diagnosis can be made on the basis of compatible cholangiography in the presence of cholestatic biochemistry, and once other causes of secondary sclerosing cholangitis are excluded. And obviously you're more comfortable to do that in the presence of IBD than you might be otherwise. I'm just going to quickly show you a slide of the sort of differential that you might want to think about, and also just flag up some of the things that I think are potential pitfalls that we should be aware of when we're diagnosing someone with PSC, especially in the absence of IBD where we may be less comfortable in that diagnosis. So it's important to be aware that there are immunodeficiency causes of a cholangiopathy, notably HIV, which is important to test for in the workup of these patients. A history, particularly regarding vascular trauma associated with difficult cholecystectomy, might point towards a vascular cause rather than PSC. Increasingly recognised, and since its description about 15 years ago, is IgG4-related sclerosing cholangitis. We'll briefly touch on that. And then really important to recognise that in patients with a new diagnosis, one should always consider whether you could be dealing with a neoplastic process, either cholangiocarcinoma complicating PSC or a HPV malignancy alone. In terms of the natural history, we've now have good data from the International PSC Study Group. So this paper published just over 4 years ago with a large number of patients collected over many centres across Europe, typically transplant centres, showing that these patients are young, less than 40 years at diagnosis. Again, almost 3/4 have concomitant IBD, and their survival is poor. Over the period of time of this study, the median survival in these patients was under 15 years, and by 20 years, around a third of patients were alive without a liver transplant. These are slightly older data, just showing the same effect, and that there's a selection bias in those patients who are under the follow-up of a liver transplant centre in the grey line here versus the general population with PSC, but showing that for a disease affecting young people, this has a poor prognosis. Coming on to discuss what is available in the way of medical therapies, you will all be very aware of ursodeoxycholic acid and its use as a hydrophilic bile acid in many cholestatic liver disorders. There's good reasons to think that this may be beneficial in PSC as a protective means of avoiding cytotoxic hydrophobic bile acids and their effect on cholangiocytes, and potentially inducing antioxidant production. The data to support this have always been poor based on small numbers of patients, and the initial positive data, now historic, were all in terms of improvement in liver biochemistry rather than any hard endpoints. And the larger studies looking at higher doses of ursodeoxycholic acid culminate in this study here that I'm just going to come on to show you in a bit more detail, which published 12 years ago. So following the initial early studies of a biochemical improvement with 10 to 15 milligrams per kilogram of ursodeoxycholic acid, a high dose urso was trialled at 25 to 30 milligrams per kilogram in a paper published in JHEP in 2009. So this was a study undertaken at the Mayo Clinic, and this study was terminated prematurely due to the increased incidence of severe adverse events, the need for liver transplant or death in the urso-treated group. This study really spelled the death knell for the new commencement of ursodeoxycholic acid in patients with PSC, and leaves us without any good evidence-based current medical therapy for PSC. In terms of whether patients who've been started on UDCA should discontinue the drug. There are no hard data, but the suggestion from the published data that are available that this is associated with a deterioration in liver biochemistry, but there are no data on outcomes. And this Kaplan-Meier here just shows you the data from this 2009 study, showing the dotted line here, the UDCA cohort who had a higher incidence of adverse events and hard endpoints in the term of need for liver transplantation or death over a protracted period of follow-up. So what are the other medical treatments that have been investigated? So the conventional immunosuppressants that we've heard used for autoimmune hepatitis and other systemic autoimmune disorders have all been evaluated in PSC. And I won't go to speak on those in any detail, but suffice to say that all of the immunosuppressants listed here have been shown to be of no benefit. I think there are two circumstances that are worth addressing. We've heard about the consideration of a PBC autoimmune overlap in the case already presented, and the coexistence of autoimmune hepatitis and PSC is a known clinical entity and reported in up to 15% of patients. This is a diagnosis that really requires compatible liver biochemistry, elevation of the IgG and positive autoantibodies, but relies upon a liver biopsy to make a confident diagnosis. And really, as you've heard from Professor Heneghan already, it's a question of treating what is the dominant condition, both histologically and biochemically, and then the treatment is as per the classical treatment of autoimmune hepatitis. You should also have an awareness that AIH may evolve over time into PSC, and so if patients with autoimmune hepatitis develop more cholestatic biochemistry, there should be consideration as to whether they have transformed into a PSC phenotype. IgG4-related disease and IgG4-related sclerosing cholangitis is increasingly recognised as a cause of biliary disease, and the group in Oxford have assessed their large cohort with PSC as to the presence of serum IgG4. Up to a quarter of those patients with classical PSC do have elevated serum IgG4, and these do seem to represent a distinct clinical phenotype, potentially with more aggressive disease. And distinguishing patients with IgG4 high PSC versus true IgG4 sclerosing cholangitis is challenging. The ratio of IgG4 to IgG1 may help to distinguish those patients with borderline elevated serum IgG4, but really it is a question of putting together the whole clinical picture, including multi-system presentation in IgG4-related sclerosing cholangitis. And in these patients, it's not really clear whether or not there is a consistent response to immunosuppression. I'll come on to talk about the role for ERCP as one of the few therapeutic measures other than liver transplantation that we currently have for PSC. So what are the data to support PSC to support ERCP in PSC? Well, these are the studies involving relatively small numbers of patients who underwent ERCP for dominant strictures. The cohorts that were compared against their predicted outcome, shown by the dotted lines here, according to their PSC risk scores, and showing a modest survival benefit at 5 years in patients who underwent therapeutic ERCP for dominant strictures. How should one intervene in patients with PSC? Well, this has been addressed by the recent DIL stent study, which was a pan-European study involving 100 patients who were randomized to either receive plastic biliary stenting versus balloon dilatation. And what this Kaplan-Meier here shows is there was no difference in the recurrence of symptomatic biliary stricturing. What there was a substantial difference in the adverse event rates favoring dilatation over stenting. And one thing just to highlight is the adverse event rate overall was 1 in 4 patients undergoing ERCP and PSC, just highlighting what a high risk in undertaking ERCP is in this cohort. I'm just going to quickly summarize the British guidelines on ERCP and PSC. So there's good evidence regarding antibiotic prophylaxis, which is advised for all patients. Before one goes ahead with an ERCP, one should recognize that this is a high-risk undertaking in patients often who have brittle liver disease. It should only be undertaken after good imaging showing a target and after multidisciplinary discussion with suitable experts in PSC. If one is undertaking an ERCP, then sampling of any dominant strictures for exclusion of cholangiocarcinoma is mandatory. And at the moment, as per the evidence I've just shown you, biliary dilatation is preferred over stenting. So what are the other potential novel therapies? Well, these are the potential targets: further bile acid therapies, immune targets, and antifibrotics. I've just prepared this slide just to show you some of the trials that are currently underway or have recently published. Most of the current trials that are published are in deal with bile acid manipulation, looking at norurso, obeticholic acid, and some novel agents that are FXR agonists and an FGF19 analog. And just to highlight that the data that are currently available are all relatively short follow-up and based upon a biochemical response, or in the latter study, a decrease in fibrosis markers, but suggest that these compounds are well tolerated and worthy of further evaluation. There are some compounds being assessed that modulate the immune system. VAP1 inhibition is being studied by the group in Birmingham using a biologic agent. And despite the lack of a biochemical signal in retrospective series of patients with IBD who have PSC, there is a phase 2 trial looking at whether vedolizumab may have a benefit. So what are the symptoms that patients with PSC experience? These are data published in the UK from a survey that was undertaken in 2014. As you might expect, itching is a predominant and pruritus is a predominant symptom, but fatigue tops the list of the patient symptoms, and depression is also prominent. What do the patients worry about with PSC? Well, there are economic and social effects and the effects of their symptoms, but their emotional well-being outstrips all of these, and the uncertainty of the condition and a feeling of helplessness are significant impacts on patients' quality of life. So I'm just going to summarize what I think and what the BSG guidelines would suggest in terms of symptomatic and supportive management. So for pruritus, on the basis of weak evidence, cholestyramine is favored as the lowest toxicity, followed by rifampicin and naltrexone. We don't have any good treatments as per other cholestatic liver disorders for fatigue and depression, but we should seek and treat alternative causes and consider treatment of pruritus as a potential cause of fatigue. It's important to remember that these patients are prone to osteoporosis, and so an assessment and treatment for this should be undertaken in patients you're seeing in the clinic. And similarly, they're at risk of malabsorption of fat-soluble vitamins, and the UK guidelines recommend a low threshold for empiric supplementation of these. There are some other considerations to have. The patients cohort, although predominantly male, a third of our patients are female and are typically of childbearing age. And so inquiring about their plans regarding pregnancy, particularly if you have a patient developing portal hypertension, is important. And the involvement of the support groups, which the patients find extremely valuable. I'm just going to finish up by talking briefly about the HPV malignancies and liver transplantation. So the International PSC Study Group data demonstrated that the incidence of HPV malignancies is high. So a fifth of patients by 20 years have experienced an HPV malignancy, the majority of which are cholangiocarcinoma. It's worth highlighting that 40% of these are detected within the first year of diagnosis. So one needs to have your wits about you when assessing a new patient. What are the evidence-based guidelines regarding the surveillance for HPV malignancies? Although CA19-9 is a biochemical marker that's available to us, the specificity is low and the routine measurement of this is not recommended. Where cholangiocarcinoma is suspected on clinical grounds, either from a change in liver biochemistry or patient condition, then this should be worked out with cross-sectional imaging, with contrast, either MR and or CT, and then a specialist cancer MDT review is essential before proceeding down the line of further confirmatory testing. And at the moment, we have a number of things available to us: ERCP with brush cytology, the potential role for cholangioscopy, which is yet to be determined, EUS guided biopsy, which is less invasive than ERCP, and potentially percutaneous biopsy. But this should all be guided within a specialist cancer MDT process. And these are the UK guidelines just outlining that the suspicion of cholangiocarcinoma may be on the basis of worsening cholestasis, and the index of suspicion really drives whether then the referral is to a specialist centre. The first line of investigations with an MRI and MRCP, and depend upon the presence of a dominant stricture, determines whether one goes for an ERCP, brushings and cholangioscopy, or down the line of further investigations to identify a mass lesion and to confirm or refute the tissue diagnosis of a cholangiocarcinoma. In terms of other malignancies, gallbladder cancer is currently recommended for an annual surveillance ultrasonography with the intervention for polyps guided by a cancer MDT. One mustn't forget about the risk of colon cancer, which is elevated compared with the general population and that with IBD. And in the UK, an annual surveillance colonoscopy is recommended in the presence of IBD and a 5-yearly examination if there's no IBD. HCC surveillance in the presence of cirrhosis as per the normal guidelines. I'm just going to briefly finish up with touching on liver transplantation. So these data put from the UK, from the NHSBT and the UK Liver Advisory Group show that PSC is a good indication for liver transplantation. So the purple line here shows that the survival after liver transplantation for PSC is as per many of the other common etiologies, and you can see those outlined here at 5 years. This bar graph just shows the overall life years lost after liver transplantation, showing that the indication is second only to PBC for the lowest number of life years lost compared with the age-matched population. When should one consider liver transplantation? This is just a schematic of the clinical course, and really we're considering patients in this section here when they have symptomatic disease, the presence of clinically decompensating events and the presence of cirrhosis and portal hypertension being the main drivers. It's often a difficult judgment call, and there are risk score calculators, and I put references to 2 of them here that do help us in that decision. One may want to assess a patient for liver transplantation and step back and watch the disease trajectory in response to things like ERCP. But the important thing is that whilst one doesn't want to be too early, you should never be too late in this condition. And just to finish up on liver transplantation, this is a question about patient selection, the management of IBD, and then a selection of an appropriate graft and a decision regarding the biliary anastomosis. I've just briefly mentioned here the possible role for transplantation for perihylar cholangiocarcinoma. This is not currently an indication in the UK, but there are favourable data from the Mayo Clinic suggesting that this could become an indication for liver transplantation, certainly in the UK, as it is elsewhere for highly selected patients. So this is the algorithm that the UK uses for the management of PSC, an approach towards risk stratification, disease staging both in terms of fibrosis and the degree of cholangiopathy, and then active management of the symptoms and any clinical events, and then surveillance for the complications that our patients experience. And this is my final slide, just to show that even in 2021, we are faced with multiple challenges in management of this condition. It's a rare disease, it's complex, and there are likely to be several different phenotypes. It typically affects a young population who have a significant symptom burden and a big psychological impact from the unknown that this disease poses. They have a high cancer risk and an unfavorable natural history, and therefore there's a high need for effective medical therapies. And with that, I'll finish, but I'm happy to answer any questions. Thanks very much.
Thank you very much, Jonathan. Very clear and excellent presentation. I think, Chris, can you introduce the next presentation, case report, please?
Sure. So to present this second case report, I will invite Dr. Raquel Fraga, who is a professor from the School of Medicine da IMED and doutora em gastrohepatologia pela Universidade Federal do Rio Grande do Sul e pós-doutora em gastroenterologia pela Universidade de São Paulo. Raquel,
Thank you, Cristine. I would like to congratulate Dr. Leila for the excellence of this event. Thank you very much for the invitation. It's a great pleasure to present this case report. The patient is a woman with 30 years old, dentist. Her medical history started in the year 2012 with recurrent abdominal pain, fever, chills, and sporadic jaundice. The magnetic cholangioresonance from January 2013 demonstrated common bile duct dilation about 1 centimeter with distal structure without stones. In the same year, the patient underwent in an ERCP that demonstrates a common bile duct dilation and papillites and papillotomy performed. In March of the same year, the patient underwent videolaparoscopic cholecystectomy with liver biopsy. A moment. The anatomopathological exam of the liver biopsy demonstrated reactive liver with portal fibrosis, antiductular proliferation, F2, F3. At that time, with these findings, the patient was diagnosed of primary sclerosing cholangitis with beginning ursodeoxycholic acid. Colonoscopy was normal. In June of this year, it was her first appointment at our hepatology clinic. Therefore, we have little information about this patient's past history. She reported continuous use of ursodeoxycholic acid for 8 years, and she presents about 1 cholangitis per year treated with ciprofloxacin. And this year, the frequency of cholangitis increased about 3 times until June. She denied diarrhea or weight loss. The exams showed cholestasis with increased alkaline phosphatases and GGT. Also a small increase in serum bilirubin and ANCA negative, antinuclear antigens, antibodies reagent, negative viral hepatitis markers. And CA19-9 was 105. Magnetic cholangiosresonance in this year demonstrated peripheral dilatation of the biliary tract with probable common hepatic stenosis duct. There is no evidence of portal hypertension. Questions of discussion: is there an indication to maintain the use of ursodeoxycholic acid in these patients? 2, patients with PSC and frequent cholangitis, is there a benefit in using prophylactic antibiotics? What is the best management in the presence of dominant biliary structures? And the last, patients with PSC who do not have a current inflammatory bowel disease, what is the frequency of IBD screening colonoscopy?
Now, maybe we could start with the discussion. So I will invite Professor Paulo Bittencourt to start with the discussion of the case. Please, Paulo, could you?
Yes, here am I again. Congratulations, Raquel, for your talk. I think that your English accent is much better than mine. She's from Rio Grande do Sul and from Bahia. We talk in a slightly different way. I would like to ask you to put your last slide with the questions for me to answer. But first, I'm very skeptical about the diagnosis of PSC. If it's PSC, it's not a classical form of PSC. In these patients, I think that we have to rely on imaging, because liver biopsy was not diagnostic of PSC, of small duct PSC, and the patient has no IBD at colonoscopy. This is not very classical. I think that maybe we have to review. It's very difficult for me, for example, to review these 3 slides without seeing the imaging in cross-sectional way. So I think that it will be good, for example, to review imaging, the RCP imaging and the MRCP imaging, to see whether the patient has another diagnosis. I thought I saw in the slide on the right that was a dilatation of the extrahepatic biliary tree, resembling, for example, maybe a very slight type 1 colorectal cyst. I think that this had to be reviewed, and also maybe rule out, for example, IgG4 sclerosing cholangitis, because at the beginning there was only one stricture in the intrapancreatic portion, I think, of the main biliary duct. And now I'm not sure because I could not see that, but it was stated that the woman has maybe a stricture in the hilum. So this is some aspects that we can see, for example, in IgG4 associated sclerosing cholangitis. So I think that before answering the questions, it would be very interesting to review imaging, to have a level of IgG4 in these patients. And even if we don't have, for example, we are not very satisfied with the results, even look for other causes of cholestasis like LPAC or low phospholipid associated cholelithiasis. But if maybe this patient, you have seen this all, and the patient has a clear-cut diagnosis of PSC, so I would like to answer the questions. I think that if you begin ursodeoxycholic acid, you have to be it will be very difficult, for example, to take out, because as Dr. Potts has said, there are some reports that patients begin off with itching and symptoms and worsening of liver enzymes when we interrupt ursodeoxycholic acid, but it's a treatment that is not covered by the public health system in Brazil. So we have to discuss with the patients to maintain. If the patient has no response after 1 to 2 years, response assessed by a fall of at least 40% in alkaline phosphatases, you are authorized to take out the medication. And for prophylactic antibiotics, I think there is no evidence-based data to avoid recurrent cholangitis in the patients with PSC. And I do not recall the other 2 questions, and I will pass to the other speakers maybe to answer, okay?
Okay. Thank you, Paulo. Dr. Jonathan, would you like to comment on this case, please?
Yeah, it's an interesting case. And I think, this is very reminiscent of what we see in our benign pancreatic biliary MDT every week. And I guess, as has been stated, it's a slightly atypical history. And in the absence of IBD, which I think is the case, one's got to have a broad mind. I think it does come down to getting all of the information available. So including that Professor Bittencourt has sort of spoken about, things like IgG4 related disease. If you have a gallbladder specimen, that's probably the best pickup rate for IgG4 staining alongside ampullary biopsies. So I would probably be tempted to try and get hold of both the index liver biopsy, if possible, the gallbladder specimen, and then review the imaging, the histology combined, along with your screen of causes for exclusion of secondary causes. I guess the concern in this lady is that she has a long-standing cholestatic disorder and now has a hilar stricture, and therefore, until proven otherwise, I think she has to be considered to be at risk of having a hilar cholangiocarcinoma, whether that's within PSC or outside PSC. I guess that's the main clinical question that we would be considering at this point. And comparison with old imaging would be extremely valuable. We weigh up very carefully, and we see sort of maybe 2 or 3 cases each week like this in our MDT, weighing up the need to do interventions like ERCP, And what we always try and do is do a holistic assessment of the patients, a clinical review to determine their symptomatology and to try and get a feel for the trajectory of their care. And that we always consider the assessment for cholangio as part of whether the patient may progress on to require liver transplantation if cholangio is excluded. So I think for the moment, it's that the diagnosis is not very clear. I think it would be helped by getting the further information that's now historic, but also approaching the current situation as a case where cholangiocarcinoma has to be excluded, and then we would discuss this in our MDT and probably end up seeing the patient in clinic, discussing the pros and cons of an intervention with them, and if the index of suspicion on imaging was high, taking them forwards to an ERCP plus or minus cholangioscopy, assessment of their fibrosis stage, and then the presence of any other features of portal hypertension. The questions that were asked, I think, possibly weren't addressed. So the question was raised about, in the absence of PSC, in the absence of IBD, how often would one colonoscope patients like this? So the UK guidelines are on the basis of fairly weak evidence, but is a 5-yearly examination unless the patient develops symptoms that would prompt re-examination more quickly. I think I would agree entirely with what was said about the removal of ursodeoxycholic acid. It might just cloud the water at the moment, because you may remove that and find that the patient becomes more symptomatic and the biochemistry deteriorates. So even though that may not have any evidence-based improvement in the disease course, it may just muddy the waters until you're clear what you're dealing with.
Right, thank you, Dr. Jonathan. Dr. Claudia Couto, would you like to tell us your opinion?
Well, I don't think I have anything to add. I agree that the diagnosis have to be reviewed, discussed with the radiologists. I even thought about a benign stenosis because the patients underwent a surgical procedure, biliary tree, but I don't know. So I think diagnosis have to be reviewed and maybe search for a cholangiocarcinoma also. And also, she has been on URSO for 8 years. It seems that it has been 8 years. And now, actually, she's presented with more frequent cholangitis. So it seems that she's deteriorating on URSO. I don't think URSO it's helping in this case, but not sure about it. And let me see any other questions. I think, no, that's all. Thank you.
Jonathan, may I ask you a practical question for clinical practice? How often you measure CA 19.9? Because I see from the young people here in Brazil, usually to measure CA 90. How can you measure it? How often do you measure in UK?
So I guess the UK guidance, which my colleagues are senior authors on, so we better follow, that suggests not to routinely measure CA19-9 because of its lack of specificity and the fact that cholestasis alone can cause a rise in values. I think where it has clinical role is one part of an assessment of a patient who has a clinical change. So the merit of checking it, I think, is when the patient has a clinical change, either biochemically, or that there's a symptomatic change in terms of pruritic symptoms or cholestatic symptoms rather, or weight loss, etc. And then I think a change in CA19-9 is one part of the investigation, but we don't routinely measure it. And the same goes really for cross-sectional imaging, and that the UK guidance is not to routinely undertake cross-sectional imaging unless there's been a biochemical or clinical change. I think that varies around the world, and I guess that the easier availability of MRCP as a non-invasive means that these patients are actually undergoing imaging quite frequently, but we try and be led by a clinical change rather than routine surveillance.
Right.
I would Raquel, I would like to ask you if you know if the imaging changed along these 10 years, 8 years, because intrahepatic biliary tree is very normal. It's strange for me. The patient has two stenoses, a distal one and a elon stenosis. I would expect a dilatation inside the biliary tree, and the biliary tree inside the liver is very normal. The image sometimes looks like a choledic cyst, a fusiform form. Have you checked this image with the radiologist?
Vou responder em português, mas assim, essa paciente, ela consultou uma vez com a gente no ambulatório agora em junho, tá? E ela fez esse exame. Eu discuti com o radiologista, o exame dela é muito estranho, porque ela tem esse estreitamento ali no ducto biliar comum e realmente ela tem uma leve dilatação intrahepática sem estenose, o que favorece que talvez ela não tenha colangite esclerosante primária, mas essa foi o diagnóstico prévio dela. O que chama atenção é que ela tinha colangites descritas por ela antes dela ter feito a colicistectomia, antes dela ter feito essa biópsia hepática, ela já tinha colestase com fosfatase alcalina e gama-GT elevadas. Lá no passado, lá em 2009, 2010. Então, a gente ficou em dúvida. E GG4 a gente solicitou, mas não tem o resultado ainda. Ela é uma paciente do Sistema Único de Saúde. A gente tentou revisar a biópsia dela, e a biópsia, a lâmina pronta dela estava muito hipocorada, não deu para ver nada. E aí a gente vai fazer novos cortes da biópsia para fazer uma nova coloração. E é isso, tem muitas dúvidas no diagnóstico dessa paciente nesse momento. E, por outro lado, tem aquele estreitamento principal, que a gente até pensou que pudesse ser até pós-cirúrgico, né? Mas ela já tinha sintomas anteriores a isso. E com essa frequência de colangites que aumentou nesse último ano, né? Provavelmente pelo próprio estreitamento.
May I pose a question to Professor Potts?
Yeah, sure.
Okay. This patient had a cholecystectomy before 30 years of age and has recurrent bouts of cholangitis. Could it be an ABCB4 related disease? Without stones depicted in imaging?
So I think it's worth considering the congenital cholestatic disorders, because it's clear that the diagnosis was present at the time that the patient had abnormal liver histology at the time they had their gallbladder out. So I think that what that tells you is that this does not sound like misadventure at the time of cholecystectomy. The patient had some pre-existing condition. Now, whether that is a cholangiopathy or whether that is one of the inherited cholestatic disorders, but I guess it does push you towards a pre-existing condition, and I think the differential for that is pretty wide. I'm not aware of a high incidence of large duct stricturing disease in the cholestatic inherited cholestatic disorders. So that's what I guess would push me away from that. I don't know what your experience is and whether you've seen a high proportion of these patients with then develop large duct stricturing disease or cholangiocarcinomas.
Jonathan, to finish, because I have to move on to Mike for the last mini talk. How often you put some stent when the patient like this has a large duct obstruction? How often you put some stent or some dilatation in that case?
So we've stopped stenting altogether in light of DIL stent. So we purely undertake balloon dilatation now, unless there are very unusual circumstances, and we are purely intervening on patients with symptomatic biliary obstruction, so refractory cholangitis, and patients who or jaundice, and in patients who've got an obvious target on imaging. and that we're limiting those to dilatation. And it may be that these patients then undergo sequential dilatation. I've got several post-transplant patients that we undertake 6 or 12 monthly dilatations for that work very well and avoids them coming to retransplantation. So endoscopy is a good treatment when applied to the right patients.
Okay, great. Chris, I think I have to move on to the last minute talk and like to introduce again Dr. Michael Heneghan, Professor Michael Heneghan.
Thank you so much. I'm not Professor Neuberger, so sorry to disappoint you all, but I'll try and do the best I can. So you'll all be familiar with the change in nomenclature from primary biliary cirrhosis to cholangitis, primarily to take away some of the stigma and also to more accurately describe the actual disease process. Now, autoimmune hepatitis is a rare disease. There are proportionally, at least in Western Europe and in Japan, greater numbers of patients with primary biliary cholangitis. And you can see here that the prevalence and the incidence varies considerably and seems to be also increasing in incidence and prevalence between the 2000s and indeed where we are 2015. Of course, there does seem to be parts of the world where it is more prevalent, perhaps in Japan, and indeed, like many autoimmune disorders, the prevalence and the penetrance of autoimmune diseases varies from place to place. And there has been a feeling that perhaps autoimmune hepatitis is not as aggressive in Japan. And indeed, the question remains with regard to primary biliary cholangitis. So this is a classic progressive autoimmune disorder that has clear genetic associations. Multiple genome-wide association studies have identified the importance of not just HLA-related areas in the genome, but out with importance of environment, the issues associated with toxic wastes and chemical exposure, hair dye, and then an immune response that results in bile duct damage and bile duct injury. And what we know is that there is destruction to intralobular septal bile ducts that can progress to cirrhosis. What we also know is that there is a progression in this. Antimitochondrial antibody positivity comes first, loss of tolerance to the pyruvate dehydrogenase complex E2, elevation in alkaline phosphatase with cholangitis, cholestasis, ductopenia, progression of fibrosis, cirrhosis, and then progression to needing liver transplantation. We also know that there are some typical symptoms in the patient journey, itching being a specific symptom of cholestasis present in various series from 20 to 70%, fatigue and up to 80%, and fatigue does not correlate with severity, symptoms of cholestasis, other autoimmune disorders, and symptoms associated with advanced liver disease. And what we also know is that untreated, the natural history of the disease is as follows. Antimitochondrial antibody positivity to the diagnosis of overt PBC, roughly 6 years. So latent PBC, 6 years. Then asymptomatic PBC to symptoms, another 5 to 7 years. And once symptoms evolve, we're looking at an evolution of 10 to 12 years. But once people start becoming jaundiced, that survival comes down. In terms of histological evolution, if you look at biopsies after 4 years, 29% remain at a relatively early stage, but this is a progressive disorder. So in terms of Diagnosis, it all hinges around the detection of antimitochondrial antibodies. If you have somebody with elevation in alkaline phosphatase and gamma GT, ultrasound, antimitochondrial antibodies exclude other diseases like you have been listening to for the last 30 minutes. Antimitochondrial antibody positivity in about more than 99%. If you don't have antimitochondrial antibodies and persistent cholestasis, negative MRCP, you need a liver biopsy, and that confirms the diagnosis. And what we also know is that the progression of PBC, it varies. We think about this interlobular bile duct problem with progression of fibrosis over a 10 to 15 year time frame, and this progression is predictable. On the other hand, there are other presentations of PBC, overlap type of situation where that curve of fibrosis is pushed over. So a more fibrotic, scarring related, and this is more likely to be seen in patients with overlap. And then the premature ductopenic variant, where you lose the bile ducts early, associated with significant itch and symptoms associated with liver failure. So the PBC journey, diagnosis is critical. We've touched upon that. The alkaline phosphatase, antimitochondrial antibody positivity, but also when you find patients who are AMA negative, you look for the specific immunofluorescence that is well characterized by rim-like staining, some other staining patterns of anti-nuclear antibody immunofluorescence. And you don't need to do biopsy unless you're looking at PBC-specific antibodies being absent, or if you suspect overlap or a degree of fatty liver. With regard to the clinical features, they vary greatly between patients. Some people completely fine, no symptoms whatsoever, to profound fatigue, other autoimmune disorders, reduced bone density, elevated cholesterol, and this is something that is variable from patient to patient. Also, do not be fooled by the fact that the absence of symptoms may predict prognosis. The prognosis happens irrespective of whether patients are symptomatic or non-symptomatic. What about treatment? Well, you've heard a lot about ursodeoxycholic acid and its controversies of whether or not it should be used in PSC. And essentially, we can categorize PBC treatment now into urso, standard first-line treatment, obeticholic acid as second-line treatment as a licensed treatment, fibrates, cheap as chips, but very, very useful, but not licensed, and then myriad of trials for new agents. And of course, urso works, it's first-line pharmacotherapy, low levels in humans. Make sure when you're treating patients with PBC, you get appropriate doses of the drug, 13 to 15 milligrams per kilogram per day. And of course, we know that it has to be in split doses, and it improves the concentration of hydrophobic bile acids so that it becomes the major circulating bile acid, and it reduces the toxicity of bile. What we also know is that the efficacy of urso is associated with improvements in liver biochemistry. It slows down the progression and it improves transplant-free survival. And these are some of the Poupon data in relation to the efficacy. It is also important not to delay treatment. If you delay treatment in patients with PBC, you also potentially impact upon survival probability. So a 2-year delay in introducing urso reduces the survival of patients. So do not delay treatment. Some paradigms in URSO management. URSO continued indefinitely. You're looking for a biochemical response to URSO based on the Paris criteria 1.67, the upper limit of normal, or roughly an alkaline phosphatase of 200. And this is how we identify patients after 1 year of treatment who are in need of second-line therapy, or alternatively, patients who are intolerant of ursodeoxycholic acid. So we use the biomarkers as alkaline phosphatase and bilirubin to assess the patients who have an adequate response. Bilirubin is not necessarily included in all of the response criteria, but when you have elevation in bilirubin, this characterizes patients into a much more advanced disease phenotype. Obeticholic acid, you'll have heard about this in some of the NASH talks in the series of liver talks. It's a FXR agonist, and that has effects in terms of inflammation within the liver. It has effects in terms of reducing fibrosis, and it has effects within the enterocyte. So this works in multiple different ways. So the FXR upregulates some of the bile salt export proteins. And in PBC, in the POISE study, what we do know is that in the double-blind phase, patients who received obeticholic acid up titrated to 10 milligrams a day, they had a biochemical improvement. And similarly, then patients who were in the open label phase, these patients continued to have benefit. However, it is only less than 50% of patients who have benefit with obeticholic acid. This is not a magic bullet. And of course, we also have to understand that these patients have a significant itch symptom. What about response criteria? Obviously, alkaline phosphatase, very important. EASL recommends an upper limit of normal for alkaline phosphatase of 1.5 with normal bilirubin, but that is not a unified diagnosis. So what I would say is think about alkaline phosphatase as the primary criterion. You'll all be familiar with the New England Journal study from the French group, 2-year open label study, bezafibrate versus placebo in patients who are URSO non-responders. And this is a different response criterion: complete responsiveness in bilirubin, normalization of alkaline phosphatase, normal AST, ALT, normal albumin, normal prothrombin time. And actually what you can see that if you use alkaline phosphatase as the sole arbiter of response, as was in the POISE study, actually the ALK-PHOS response are very favorable. Now, are we comparing apples and oranges with obeticholic acid and this drug? The answer is maybe. There's some criticism that this was less advanced disease, but unquestionably the alkaline phosphatase bilirubin response was significant, and there was also signs that liver stiffness was also impacted significantly. This slide summarizes the various response criteria. I'm just putting it here for reference, but think about alkaline phosphatase, the upper limit of normal, Paris 2 criteria, 1.5 times the upper limit of normal, easy to remember, but alkaline phosphatase less than 200. Now, what about the real world data of obeticholic acid? Well, the take-home message here is that obeticholic acid in an Italian cohort of predominantly women, the response rates is as low as 43%, so not as good as we actually believe. What about the sequential addition of obeticholic acid and fibrates? So this is a study, 58 patients, OCA followed by fibrates versus fibrates followed by OCA. What you actually find is that there is a 22% gain in alkaline phosphatase reduction at 1 year, and triple therapy, you can use it. It is associated with a 3-fold increase chance of reaching normal alkaline phosphatase, or triple therapy if you are using Paris 2 or Toronto criteria being reached is 6.8. Interesting, if you are dealing with symptoms of itching, fibrates are very, very helpful, and you get a better response in itch if you're using urso followed by obeticholic acid followed by fibrates. Now, one of the other key questions, and this is a big Japanese data set, almost 4,000 patients, 3,162 on urso, 746 on urso with bezafibrate. And what you can see is that patients who receive dual therapy, their likelihood of needing transplant is significantly less. And what you can also see is that if you look at the sequential follow-up of patients, the outcome of patients followed up in Japan sequentially, the outcome of patients with PBC is improving over time. There are a range of phase 2 and phase 3 clinical trials. These are some of the agents: seladelpar, probiotics, elafibranor. Some people are still convinced that PBC is a viral-driven disease. Some ileal bile salt transport inhibitors, IBAT inhibitors, are being used for the itch, as well as mindfulness interventions. Elafibranor, a mixed PPAR alpha and delta agonist. There's a phase 3 trial study underway at the moment. These are data from the Journal of Hepatology published this year in the phase 2 study. You can see a significant improvement in alkaline phosphatase, but also a reduction in the itch signal in up to 50% of patients compared to placebo. So this is very important. The other key in managing patients is symptoms. And of course, if you're managing fatigue, you need to rule out other causes of fatigue like anemia, depression, sleep disturbance, thyroid dysfunction, and look at other medications such as antihypertensives that can impact upon fatigue. And if you do have patients who have significant fatigue, Provigil or modafinil can be used. There was a study using rituximab which did not work. Itching is the other dominant symptom. It's present in up to 70% of patients, multifactorial etiology. And it's, again, your management should be thinking about cholestyramine as a first-line treatment, and then followed by rifampicin, naltrexone, sertraline. Don't forget the extrahepatic manifestations of this disease in terms of osteoporosis, dry eyes, dry mouth, and hyperlipidemia. And of course, although patients with PBC may not be at increased risk of death from atherosclerosis, if they do have other risk factors, they should be treated with statins. And of course, this is where bezafibrate actually has an additional effect because of its effect on lipids. The complications of chronic cholestasis, these are some of the rates in studies, the complications related to cirrhosis. So even though the risk of hepatocellular carcinoma is incredibly low, don't forget about it. So to summarize and to finish, PBC is a classical autoimmune cholestatic liver disease. Genetic factors and environmental triggers. The progression is variable. Think about early diagnosis and think about antimitochondrial antibodies, alkaline phosphatase, biomarkers to assess response. And while URSO is effective for many patients, you still need to be thinking about second-line therapies. And biochemical response is probably the critical marker that we need to be thinking about. So thank you so much for your attention, and we'll move on to the cases.
Okay, Michael, thank you very much. Indeed, you're very on time, 15 minutes bridge time. Thanks to, I don't have any case, but I have 4 minutes to close the section. I open to debaters. If you have any questions, very quickly, you could ask Professor Heneghan. I like your picture from Roger beside on the back.
Yeah, it's very moving. It's a picture of Roger, myself, and actually Rajiv Jalan taken
in Jalan, yeah,
at Basel, British Association study of the liver 2 years ago. So it's very poignant.
I have a question to Dr. Heneghan. Thank you. It was a wonderful presentation. I'd like to ask you if in daily clinics you can predict patients who will not respond, because we know we have to wait for 1 year. But if in the middle of this way, you just predict, well, this patient won't respond, I need to think about the second therapy.
So I think you're absolutely right. Usually you can tell within 6 months of patients taking ursodeoxycholic acid whether they're responding or not. I have no doubt that is the case. I think that at the moment we're at a point where we are going to see an explosion of therapies in PBC in the same way as we're going to see an explosion of therapy in NASH. And I think it'll be very interesting for patients. And I think we probably should be more aggressive early on rather than waiting for things to evolve.
Thank you. Cláudia, Cançado.
Eu gostaria, I would like to say the opinion of Heneghan about 2 points. I'm very impressed with PBC patients. The first one, young patients, young women with PBC, they usually have a very aggressive disease. Sometimes they seem like overlap syndrome. Many of them use corticosteroids. I think PBC has a very aggressive course in young women. What do you like about this?
So I agree entirely with you. I think the youngest patient that I've seen with PBC is a diagnosis at the age of 18 or 19, went on to be transplanted at the age of 30, retransplanted at the age of 34 with recurrent PBC. So there is a very specific phenotype that does go on. I think there are this group of women who I have given steroids to. All I seem to have been able to manage is turn them into diabetics with steroids, to tell you the truth. But I do think that these are the group of patients who probably benefit most from this triple therapy of urso. Introduce if they're not responding within 6 months, a year, absolutely add on obeticholic acid and escalate the dose as quickly as they can if you can tolerate it. If they still have transaminases, perhaps a trial of steroids, but inevitably you know that these women are going to be transplanted.
Another point I would like to know is about neoplasias. I'm very impressed with the number of neoplasias in PBC patients. I have patients with 3, 4 different kinds of neoplasias. The most of them thyroid, breast cancer, stomach and colon. Of course, hepatocarcinoma also. What do you share this opinion with me?
So what I would say is the thyroid cancers probably are coming because they're more likely to have a pre-existing thyroid dysfunction. I have seen some thyroid lymphomas actually in women from the Gulf or from the Middle East. I haven't really seen I've seen lots of breast and ovarian cancer. I haven't seen the stomach cancers particularly, but I think there is no doubt there is a systematic review that was published, I think in Hepatology in 2012, that showed that men with PBC were slightly more likely to have stomach cancer rather than necessarily women. But I think, you know, it's the common cancers.
One more question because I have to close this section. Any question, Paulo or Claudia, to close it? No? Okay. I have to say thank you very much again to my colleagues from the United Kingdom, especially Michael Heneghan, to help me to organize this roundtable, and also my Brazilian colleagues that who are experts in autoimmune liver disease in Brazil. We have 587 participants, and they may over 100 in the main room. Thank you very much indeed. See you next Tuesday with Acute Liver Failure with Julia Windon, also from King's College. Okay, bye-bye. Cheers.